Thank you to the IAP, Professor Singaravelu and all the colleagues, and Dr. Modi, Dr. Rawat from the National Respiratory Chapter as well. You're doing an amazing job, and obviously from this meeting, the way it's organized extremely professionally, I am honored to be with the chairpersons for this meeting and the experts. I mean, it's interesting to note that we have PGI connection, so I did my DM neonatology in PGI as well. So very privileged to be with you, and to have pediatrics and clinical genetics background is excellent. And interestingly, the cases we discussed today will have such links as well. So I'm proposing to take 35-40 minutes of the time initially. There are 3 cases, not 2. I just made it more interesting by adding the 3rd case, which will be quite challenging as well. And pulmonology and neonatology are closely linked. Most of the respiratory conditions need support, and though we don't involve the pulmonologist in the acute phase, as we get into the chronic stages, BPD, airway problems, so pulmonologist starts getting involved. And we always have challenges in terms of the wheezing in the premature babies. I mean, many of them behave atypically, though it's not asthma, they do have significant asthma-like presentation in early infancy, which most of you would be seeing. So as Dr. Rawat kindly introduced, I mean, I would request you to go to my YouTube channel as well. Lots of interesting lectures covering different aspects of respiratory care in babies, as well as general pediatrics if you're interested. So in the first case is a term baby born by elective cesarean for previous section. Non-consanguineous marriage, the parents were of Afghan ethnicity. There are no risk factors in the pregnancy except maternal diabetes. The baby had a birth weight of 3.6 kilo. So as it always happens, it starts as if it's a normal case. So we have a term baby with respiratory distress. We started the baby on CPAP. And then we did the blood gas, and unexpectedly there was a very high CO2 on the blood gas, which was persisting, and the baby had a high FiO2 as well at that stage. So we decided to intubate and ventilate. The CO2 was initially 70 on the capillary gas with the wound heel. The oxygenation was well maintained. The pressure requirement wasn't high at that stage, and the FiO2 had come down from 50 to 25% once we ventilated. But the PCO2 continued to rise. So it went to 90 from 70 and 110 millimeter mercury. So the baby had increased effort and there was retractions despite the intubation. So we decided to give a loading dose of paralytic agent to take out the effort of breathing, and it seemed to resolve the problem. So this was the chest X-ray, which is unremarkable, well-inflated lung fields, ET tube in position, the feeding tube in position. So we didn't have any clear diagnostic clue at that stage. After the baby was paralyzed, the CO2 reduced well, and we had the end-tidal CO2 monitor from the Philips itself, which could be connected, and continuous monitoring of CO2 was available. On that, we noted that as soon as the paralytic, we only gave a loading dose of the paralytic, not an infusion. So as soon as the effect weaned, the baby showed agitation. Then we could see on the sensor, the ATCO2 started rising again. The CO2 increase was confirmed on a blood gas as well. So we wondered what could be the reason. It's not a lung disease, pathology is not significant. The baby is well built and activity levels are normal. It's not a neuromuscular, and of course you have intubated and mechanically ventilated. So despite the ventilation, the baby had a rise in CO2. So we considered possibility of airway related problems. We continued the paralysis as an infusion at this stage, and the CO2 came back to normal. It was maintained, and we discussed with the pulmonology and arranged a CT of the neck and the upper chest. So interestingly, the CT showed narrowing here. As you can see, this is the tip of the ET tube, which was a bit high at that stage, and you can see that just above the carina, you have a segmental narrowing of the trachea. So what was happening is that when the baby is agitated, obviously the increased inspiratory effort and the negative pressure in the thorax was causing the trachea to collapse, and that was causing the absence of gas exchange, or significant CO2 retention was happening. So we were able to overcome this when we paralyzed, and that's how the clinical management was working at that stage. We decided to bypass the stenosis by pushing the ET tube deeper, We measured it so we don't reach the carina itself. So just above the carina, we stopped. And once we did that, we could wean off the paralytic agent. The baby was stable. We started the feeds by tube feeds. The blood gases had no trouble after that. So no sedation, no paralysis, just the ET tube to keep the airway stented at that stage. And because we were not a referral unit, we sent the baby to a referral hospital where the baby was operated. I had the immediate update that the baby did well, but I don't have the details of what procedure was done. So this case was a congenital tracheal stenosis, and it's a potentially life-threatening problem. It's often caused by complete tracheal cartilage rings and absent membranous trachea. So obviously the flexibility is lost, or sometimes the airway cartilage is not well formed, as in this case, it was collapsing. So the collapse could happen either at the site of the stenosis or just beyond that. It's rarely caused by irregular circular cartilaginous plates or disorganized cartilage. This case probably is a disorganized cartilage. Cantrell and Guild classified it as either generalized hypoplasia or a funnel-shaped narrowing or a segmental stenosis, as in our case. So it's usually associated with bronchial abnormalities or vascular abnormalities as well. And the clinical presentation can be mild, where baby may have intermittent stridor or occasional symptoms, or moderate with respiratory symptoms without respiratory embarrassment. Coarse cough could be associated, or severe symptoms like in our case with significant respiratory difficulty. So the diagnosis is typically made by rigid laryngobronchoscopy under general anesthesia, and you can do virtual endoscopy to evaluate the post-stenosis bronchi distal airway anatomy, and HRCT could help to review the endoluminal images up to the segmental bronchi. MRA could help to delineate the associated vascular anomalies, especially, and if there are lung segmental changes, you could pick up as well. And of course, echocardiography is essential as well due to the associated cardiovascular or vascular anomalies. So if the child presents with symptoms suspicious for congenital tracheal stenosis, which is respiratory distress, inspiratory wheeze, and cough and stridor, then you do the echocardiogram as well as CT. And if there is a vascular sling, you think about rigid bronchoscopy if to see associated airway problems. If there is no cardiac malformation as well, you would go to bronchoscopy. And once the bronchoscopic diagnosis is made, you assemble the multidisciplinary team and then decide for the therapy accordingly. Mostly, it's conservative management for the mild cases. Endotracheal stents can be used. Till we transferred, in this case, we use the ET tube as a stent bypassing that stenosis. A pediatric patient can typically tolerate up to 50% narrowing of the tracheal diameter, but remember that any of these babies could decompensate with RSV or bronchiolitis like picture, or the narrowing of the upper airway with nasopharyngitis could complicate because the resistance to the breathing increases significantly, and then they may decompensate with a viral infection. So always warn the parents that if there is a sign of viral infection, they should be extra careful. The surgical options would include resection and primary anastomosis. Could do a patch tracheoplasty, non-tracheal autologous tissue, costal cartilage or pericardium could be used, and slide tracheoplasty, which is a significant procedure. Tracheal transplant is probably not done in majority of the centers. So the slide tracheoplasty is where the trachea is vertically split and you widen it, similar to what surgeries are done in the GI tract as well. So it needs a huge level of technical expertise. I'm not sure if the experts have seen it in their centers. The prognosis depends on the severity, timing of presentation, the nature and length of the stenosis. The milder types have a good outcome. The exercise limitation may happen, especially with intercurrent infections. In the severe type, it's a high surgical risk as well, and unfortunately, not many centers would be capable of doing such major surgeries. So if they are lucky enough to reach a center, they might survive. Otherwise, the severe cases may succumb. And remember that the immediate airway management needs expertise as well, and you may use a smaller ET tube. You may need the anesthetist to intubate such babies as well. So the outcome is improving with recent advances in surgical technique and supportive treatments as well. So with that, we conclude the first case. I will discuss the second and third cases as well, and probably have the discussion together in the end, if that's okay. So the second case, we have a term baby born to a gravida 4 para 3 mother by elective cesarean. These parents were of Pakistani origin, and gestational diabetes is well controlled. The parents are first cousins as well. The baby was well grown, 3.8 kilos, and was transferred to the NICU after the delivery, again thinking of transient tachypnea. The baby was started on CPAP, and because of the high oxygen requirements and increasing work of breathing, we changed to NIPPV, which is a non-invasive form of ventilation. And baby responded well to that. The chest X-ray was suggestive of transient tachypnea. The blood gases showed initial respiratory acidosis, which improved. As the normal protocol in our unit, we gave ampicillin gentamicin for 48 hours and discontinued as the blood culture was negative and CRP normal. Even though the baby continued to be symptomatic, we didn't continue the antibiotics, which is the right practice. Baby was started on tube feeds and weaned off IV fluids. Baby stayed on NIPPV and attempts to wean was not successful. So normally we would expect TTN to improve by 3 to 5 days at least, even in the severe cases. So if it extends to continue that, we start thinking about alternative causes. So there was no evidence of infection, and the secretions were not significant as well. We had an informal discussion with the parents because parents often start getting agitated when the baby doesn't improve as they expect. In Dubai, we have insurance, and so the cost of the treatment is not a huge issue. But I know in India, the cost also starts escalating, and that leads to the parents getting more agitated as well. So we said whether there was any underlying cause like cystic fibrosis. At that time, the mother mentioned that the baby's sibling, who was 10 years old at that time, he gets recurrent sinusitis and has a heart disease. And then when I probed, they said he has a dextrocardia with the VSD. So immediately I thought it could be a primary ciliary dyskinesia causing this persistent distress in the baby, as it has been well reported that prolonged TTN-like picture could be related to PCD. So the baby was started on regular saline nebulizations. I told the parents this possibility and they calmed down significantly. I just told them it needs another week or two to recover and we will work up for this. But at the same time, you don't need to panic because it's persisting. So the parents were trained in suctioning and nebulization and so on so that we could discharge the baby at the earliest possible. So the baby weaned off the NAPPV to CPAP and then over 2 weeks weaned off the CPAP, established suck feeding and discharged home. Even though we were prepared for recurrent infections and so on, this baby had a relatively stable course. First few months, there was some viral infections, but apart from that, nothing major. The ENT review was done and we sent a nasal mucosal biopsy to confirm primary ciliary dyskinesia. It was sent to US, lab in US in the appropriate material. The test was done around 2 weeks just before discharge, and it took another 2 weeks for the result, which confirmed primary ciliary dyskinesia. And the older sibling obviously has Carter-Jenner syndrome, and both are in the same spectrum. So as I said, the baby was growing well and just given the training to the parents, and this baby did well. I mean, now the child is around 5 years old. We counsel the parents about avoiding consanguinity in the family, which is very common in the Pakistani families. So primary ciliary dyskinesia is a rare problem. The incidence is 1 in 16 to 20,000 deliveries. The presentation is either in the neonatal period with persistent distress. This is not the common presentation, but as a neonatologist, when we see such cases, always keep that in the background and look for family history or other features in the child. And the baby may present later on with recurrent respiratory and sinus infections. There can be associated dextrocardia and situs inversus in 40 to 50%. Bronchiectasis, sinusitis, infertility are the associated findings. And 6 to 12% have heterotaxy syndromes with asplenia, polysplenia, and Ivermerk syndrome. Life expectancy is good usually with supportive treatment and timely antibiotic treatments. In the severe cases, because of the risk of bronchiectasis, you need to choose the right antibiotics, almost like you manage cystic fibrosis cases. So it was initially described as immotile cilia syndrome, but then the study showed that the cilia were motile, but they exhibited a stiff, uncoordinated or ineffective beat. Then the name was changed into primary ciliary dyskinesia or dysmotility. So there may also be secondary ciliary defects when there are multiple causes of epithelial injury. For example, smoking is an important factor, and working in polluted environments can affect your ciliary function as well. The cilia and flagella evolutionary ancient organelles. So even in the protozoal species, you would see the amoeba has a single cilia at the top. The structure and function is rigidly conserved across the phylogenetic spectrum. They have a role in cell motility as well as transport of fluids over the mucosal surfaces. They also have a sensory function that modulates elements of the development and cell functions. For example, we have cilia in the renal tubules and so on as well. Both the motile and sensory cilia are composed of highly organized arrays of microtubules and their accessory elements. So this is the structure of cilia in the respiratory epithelium. So we have the microtubules, 9 pairs outside and 2 microtubules in the center. And we have the dynenorms, the outer dynenorm and the inner dynenorm, which are responsible for the direction of movement. So the Nexin link connects the outer microtubules, while we have the radial spoke, which connects the central with the peripheral microtubule. So the ones that are beating back and forth will have this structure, while the ones which have rotatory movement or non-motile ones do not have the central microtubule structure. So you have basically the motile cilia, which is the planar motion one. Mostly they're on the epithelial cells, the brain ependymal cells, the respiratory airway epithelium, reproductive tract, and also the sperm. And in the embryo, we have the nodal cilium, and that's why we have the asplenia, polysplenia, malrotation, and so on. So when we have embryonal development and the axis of development changes in the organs, it's mainly because of these. And that's why dextrocardia is one of the associations with ciliary dyskinesias. And we have the non-motile cilia in the kidney, tubule, bile duct, pancreatic duct as well, eyes, where it is connected to the photoreceptor. So there is an association with retinitis pigmentosa-like symptoms. And in the ear as well, the kinocilium is having ciliary motility. So you can see here, this is the normal one. And here the both arms are absent, and different variations of the dynenorm absence. And here we have a small video showing you the normal ciliary motility, back and forth movements, very organized, coordinated, and you can see how effective our ciliary motility helps to function. And we have the rotary, irregular, incoordinate movements in primary ciliary dyskinesia. So it's not going to be in one pattern, and you can see different areas are moving in different patterns. So this becomes incoordinated, and it's not going to be really helpful to clear the secretions. So the gold standard is electron microscopy of the ultrastructural biopsy from nasal scraping or bronchial brush biopsy. There are genetic tests available as well. I'm sure we will have this panel developed soon. And nitric oxide measurement on the nasal mucosa is tested. Nasal nitric oxide is very low. It's 10 to 20% of normal in patients with PCD. So again, this test is not routinely available, but in the referral units where we face such cases frequently, you might see that. The clinical features include different organs as we discussed. So the middle ear is affected, chronic otitis media, hearing loss, and the paranasal sinuses, nasal polyposis can be seen. Sinusitis is common. And in the lung, we have the prolonged neonatal respiratory distress. This is not severe, but prolonged. And we have the recurrent pneumonia, bronchiectasis as well. In the genitourinary tract, male mainly, but possibly female infertility as well. And the situs inversus heterotaxis syndromes due to the embryonal model that we discussed.
Sorry to interfere, Sridhar sir.
Yes.
Many people are...
Sorry?
You're mute, sir. You're mute.
Sir, continue, sir, please.
No, many people were saying what?
Well, voice loud, a bit louder they want, sir. They want.
Yeah, sure. Thank you.
Thank you.
So in the eyes, you can have retinitis pigmentosa, as I mentioned, related to the... So the situs inversus totalis occurs in approximately 50% of patients with primary ciliary dyskinesia, and we said 6 to 12% might have right isomerism, IV mark, and polysplenium as well. The chronic wet cough needing a recurrent antibiotic therapy in a child should also prompt testing for PCD if you have suspicion. Cystic fibrosis also would be looked at if you have a family history. So you look for all these features and they're present, you have index of suspicion. So I mentioned a neonatal case, but many of your pediatricians, you might be seeing recurrent cough, wheeze, and chest infections. You may have to think about it. It's not that rare, though it's not that common as well. So we have a cilia expert as well. So hopefully she'll comment on how she sees in practice. So the life expectancy is good in such cases with supportive management and timely antibiotic therapy and preventing bronchiectasis. So timely use of antibiotics, saline nebulization could help. Ventilation in the room the child is in, avoiding pollution as well, if possible. And obviously, if bronchiectasis does develop, they need expert management with the pulmonology team. And ENT problems need ENT referral, and infertility counseling and so on is important as well. So coming to the last case, this is a baby born at 35 weeks, 2.2 kilos, small for gestational age. It's a gravida 2, para 1 mother. The father is a second degree consanguinity, second cousin. The first baby is healthy. The baby was born by emergency cesarean section for breech, did not have to come to the NICU. Baby had sugar monitoring because of the mother having diabetes in pregnancy, no other antenatal concerns. The scans were normal in pregnancy as well. During the initial admission, the blood glucose monitoring was normal. The baby had feeding support and was clinically stable and discharged home like a normal baby by day 3. However, the baby presented to the emergency on day 5. Baby was due to have the post-discharge visit in the same evening. We had noticed acute blueness with breathing difficulty that afternoon after a feed. The saturation was 70% in room air at the ER review. The baby was started on mask CPAP and oxygen. Saturation improved. Baby was shifted to the NICU on high flow nasal cannula, and the blood gas was reasonable. pH 7.37 and CO2 48. The blood count, CRP, renal and liver functions were normal. The viral screen was negative and the blood culture was negative as well. So again, we gave ampicillin gentamicin at admission, but stopped it after 2 days as the CRP was thrice normal. The pediatric cardiology done echo showed severe PPHN at admission. The TR, the pulmonary pressure, there was tricuspid regurgitation and the pulmonary pressure was suprasystemic at 67, and there was a right to left shunt through the PFO. Clinically at that stage, we thought whether the baby had an aspiration pneumonia at home, and obviously being an IUGR baby with high risk of PPHN, the baby could have gone into the persistent fetal circulation physiology, the hypoxia provoked by the aspiration. The baby was clinically stable on the non-invasive ventilation, but continued to need 30 to 40% oxygen, had persistent subcostal recession, so high flow could not be weaned. So this was the chest X-ray, and at that time, it seemed consistent with the picture we had seen clinically. The repeat echo the day after the admission showed improving PPHN picture. Obviously, the hypoxia had corrected and the PPHN started improving. The baby was kept on OG feeds. Where our practice is to keep the baby on full OG feeds if they are stable on non-invasive ventilation, but we don't offer suck feeds till they are off the respiratory support. The baby had a TSH of 29 on the newborn screen, and we repeated at that stage it was normal. The chest X-ray was repeated after 5 days because the baby wasn't improving as we would expect. And here we could see more fibrosis pattern, or the streakiness was very clear. So we wondered whether we are dealing with interstitial lung disease. And the baby was started on nebulized budesonide as a trial, just thinking whether the lung inflammation related to aspiration pneumonia. And we thought we will give it a trial for a couple of days and then do a chest CT to rule out interstitial lung disease at that stage. So the chest CT was done after counseling the parents. So this clearly shows the thickened interstitium, bilateral and almost homogeneous. So it was there in multiple cuts as well. So bilateral diffuse thickening of the pulmonary interstitial septation, picture consistent of diffuse interstitial disease. So they suggested lung biopsy. We referred the baby to a center with pediatric pulmonologist. The baby continues to be on high flow, and they considered congenital interstitial glycogenosis as a most likely diagnosis. They started pulse steroid and hydroxychloroquine. Initially, there was a response, but then it started stabilizing at the same level. They sent genetic workup, and I think the family flew to Germany for further management. I'm not updated on the last picture. So this is a good review, and I'm sure you'll find many good reviews on this topic as well as updates. Interstitial lung disease is a group of disorders which involves both the air spaces and the lung interstitium, and results in diffuse lung disease. It's very rare, but it's associated with significant morbidity and mortality, and the prognosis is quite variable. Some of these conditions may result in fatality in the labor room, while some may survive with the long-term support. And the lung histopathology is a gold standard, but we have significant progress in genetic diagnosis, so we may be able to diagnose more and more of these conditions by genetic testing. So the characteristic clinical and imaging features may allow the specific diagnosis. We have the grouping of these conditions into subcategories. So the developmental disorders are the ones that present fairly early, and I will mention that next. We have growth disorders, which could be either congenital or related to prematurity and related factors like BPD, where the lung growth is disturbed. We have the surfactant dysfunction disorders. Again, they could present acutely with surfactant apoprotein B deficiency or RDS, which doesn't respond to your typical management. And there are specific conditions of unknown etiology, which are unique, like the interstitial glycogenosis we mentioned as well. So the prevalence, it varies a lot depending on whether you're including the severe cases or the mild cases as well. So 0.13 to 16 cases per 100,000. The developmental disorders, the most severe is acinar dysplasia. So I had one case of acinar dysplasia where we went for resuscitation. The baby cried immediately after birth, but then there was zero oxygenation, and we did a postnatal MRI, postmortem MRI. We couldn't save the baby because there was no oxygenation happening, and the postmortem MRI was consistent with lung hypoplasia, poor development. There was hardly any aeration, and then the biopsy confirmed acinar dysplasia. So the baby has a normal neurology and the reflexes are normal, so the baby cries. This is a scary situation to both the obstetric and pediatric teams because you wonder what went wrong subsequently. And these children are difficult to support because this is not compatible with oxygenation. We have congenital alveolar dysplasia, which is also a developmental problem. There is an arrest of lung development in the alveolar stage, late canalicular to saccular phase. And these infants also have severe lung disease. And as with any severe lung problem, pulmonary hypertension is present. They can be supported and the diagnosis established by biopsy. But most of these babies succumb later on unless you do a lung transplantation. The alveolar capillary dysplasia with misalignment of the pulmonary veins is a larger category as well. And these babies present with severe hypoxemic respiratory failure and pulmonary hypertension present shortly after birth. They're quite difficult to manage and usually leads to death in the neonatal period. So the typical pattern of this is the lung biopsy findings, and there is a genetic background to it. The FOXF1 gene linked to the pulmonary vascular development as well. You always consider this in a very refractory PPHN where baby doesn't respond to the treatment. So in typical cases, you have a thickened interstitium, poorly developed capillary bed, the lobulation is abnormal, and the pulmonary veins run in the same bronchovascular bundle as the pulmonary artery. So that's why we call it the misaligned veins, alveolar dysplasia with misaligned veins. In the normal situation, the pulmonary vein runs in the intersegmental septa, while the pulmonary artery runs alongside the bronchi. So it's a different situation. The alveolar growth disorders, mainly BPD, where there is cystic changes in the lung as well, CCAM or CPAM are also in this group of conditions. And we have the surfactant disorders where the baby presents a severe RDS, surfactant apoprotein B deficiency is well known and it's inherited as well. And we have congenital alveolar proteinosis where there is alveolar membrane leaking and similar to the surfactant protein B deficiency in presentation and severity. We have the neuroendocrine cell hyperplasia of infancy. We discussed the primary ciliary dyskinesia as a cause of persistent TTN. This also could lead to persistent TTN-like symptoms. And the index case we are discussing, pulmonary interstitial glycogenosis. The biopsy findings include interstitium widened by immature mesenchymal cells, which contain glycogen. So you can do a PAS staining on electron or do on electron microscopy. And there is relatively little inflammation in the lungs in these cases. So both these cases tend to improve with time, and you have some response to steroids or immunomodulating treatment. And of course, primary ciliary dyskinesia itself could present with interstitial lung disease pattern. The case was discussed earlier as well. So to conclude, interstitial lung disease is rare and it's challenging to manage. The prognosis is often unpredictable and poor, and we have to be careful with counseling of the parents. We should not give them hope more than what is possible. And obviously, some cases may not even go past the NICU stage. So it depends on the severity and luck, and obviously the family pattern may help you predict. So to summarize, we have discussed 3 different cases, varied pathologies, and we have to be alert to atypical cases and how to approach them. We are not experts in the field, and the pulmonologists and the respiratory experts are going to be the experts in the field. We do need significant input from genetics as well. And I think any case-related questions, practical questions I will take, and the complicated questions I leave it to the experts. Thank you.
Thank you, sir.
Thank you so much, sir. Very nice presentation.
Thank you.
Kundu madam, your comments, please.
Thank you for the excellent cases that you have presented. I will share my experiences in this field because we've been working in these fields and the challenges that we face in diagnosing these conditions, and I definitely compliment you for your diagnosis. Your first case, which you talked about, the child who presented with the tracheal stenosis, right? So I think the tracheal abnormalities of all the upper airway abnormalities, the tracheal abnormalities are the rarest congenital malformations. And fortunately for you, your child, we at our center do a lot of airway work, including the tracheal surgeries that you mentioned. It is routinely done at the center, that is the NHS RCC hospital center that I work with my airway team. Just to share an experience, we had a child recently who had a Pfeiffer syndrome, a craniofacial abnormality. And why I want to share is because this is rare and one may not see it in a lifetime, because there are only a few, I think less than 100 case reports in the world. And this was a child who presented to us with stridor. So we were thinking in terms of either a tracheal stenosis, a malacia, or a bronchomalacia. And this child had something called as a tracheal sleeve. Okay, and the sleeve is absent. The whole thing is a cartilage. So it's not like a complete tracheal ring, but it's a complete tracheal sleeve. The whole thing is made of cartilage. The prognosis in these kids is poor because as they grow older, their respiratory requirements cannot be met with the amount of air that will pass through the trachea. For your case too, lot of challenges in diagnosis. If you look at the ATS guidelines versus the European guidelines, they are different. How a European society would diagnose PCD versus the American Thoracic Society. So the American Thoracic Society, the emphasis is more on genetics, okay, where approximately up to 60% of cases can be picked up, because we know there are 30 genes involved in PCD. So the number of mutations possible are huge. So until we have our own database, it will be very difficult to pick up. But they rely more on doing a nasal NO screening, followed by doing a TEM, that is your tandem electron microscopy, and followed by genetics. Whereas in the European Respiratory Society, they rely more on high-speed video microscopy and TEM, then followed by genetics, because if each of these tests has a fallacy. So diagnosing PCD is a challenge because you have to depend on multiple tests given a clinical phenotype. So based on that, you would do a screening with the nasal NO, and then you would either do TEM or high-speed video microscopy and confirm with genetics. But standalone one test is not enough. So we at the SRCC Children's Hospital set up a lot of things. We've started doing nasal NO. The challenges we face in the Western world, they will do 3 times on both the nose. For us, one thing costs a lot. So we manage with just doing one. We cannot do it in children below age of 5 years because the guidelines or the standardized values of the nasal NO are for children above the age of 5 years. But there are few studies now between the age group of 1 to 5 also by Dr. Jane and her group. And so we have started a small study doing nasal NO in smaller kids. We also set up high-speed video microscopy. Lots of challenges there. The high-speed video microscopy that you do, you don't know whether it's a primary ciliary dyskinesia versus a secondary ciliary dyskinesia, because if these kids always have a runny nose, so whenever you take, you will see the cilia not beating properly. So you don't know whether it's primary or secondary. So we have a current study going on with the Mumbai University, where we are doing cell cultures. So we are taking these cilia, yesterday we sent 5 samples. We do a cell culture, and after 3 months, we then look at the cilia beat to know whether this with the primary ciliary dyskinesia versus secondary ciliary dyskinesia. Again, we are not doing TEM at this point of time, but the high-speed video microscopy we have sent up in an indigenous method. We bought a camera from China, we fixed it onto a microscope, and we have started doing it. And when we do this, we don't really look at the beat frequency, but we look at the beat pattern. But here also we know there are lacunae, as I already mentioned. Even if you do TEM, 20% of children who have ciliary dyskinesia may have a normal 10. So you can have children without any electron microscopic, tandem electron microscopy abnormality and still have ciliary dyskinesia. So each test is not exclusive. So we have to do a lot. We are in the process of even tying up with immunofluorescence with Mumbai University because they are doing it there. So again, there the problem is getting the correct match for the antigens on the cilia to pick up on immunofluorescence. So there are a lot of gaps, and we also looked at, we have a cohort of close to 30 patients with ciliary dyskinesia, 2 families with Cartagener's syndrome, where one family has 3 children with Cartagener's and the other one has 1 child. And we have a child with retinitis pigmentosa with ciliary dyskinesia. So we have a big cohort of children, and we have a large number of patients who on genetic tests are heterogeneous and who are behaving like ciliary dyskinesia. So we have to even treat them. So we are sending samples out of the country even to look at a wider mutation study where our geneticist, Dr. Inusha, may add. So to look at that, whether we don't have those mutations which we possibly think this could be a possibility. So in ciliary, I think there's a big amount of work that can be done in this field, and it's extremely fascinating.
And probably the approach to the treatment isn't much different, isn't it? Whether you
Yes.
diagnose it or not, you can do empiric clinical diagnosis, and the management isn't different if they can't afford or.
Yeah, but the thing is to pick them up early and to treat them. That I think that's the key, and it's better than cystic fibrosis. We also
Yes.
applied the PICADAR score, which is again a ERS guideline, which looks at a clinical score when you suspect a cystic fibrosis. We found that the results were not so sensitive enough. So I feel even if you don't have, so I feel the problem in the PICADAR score, it talks about wet cough starting in infancy. My clinical, whatever data I have and whatever experience I have with PCD, I feel if you have wet cough, even in slightly older kids, 2 years or 3 years, it still could be PCD, and you must keep your suspicion open over there.
Correct.
Yeah, so it's recurrent wet cough in children below age 5, and it need not be infants, and you can still think you can still think of PCD. As regards your last case goes, fascinating case, but I think this child has got alveolar proteinosis with a mutation of NK, it's called NKK1-2 mutation, which has hypothyroidism with alveolar proteinosis. It is your surfactant metabolic, surfactant protein dysfunction disorder, because they have hypothyroidism, poor
This
neurology.
baby didn't have hypothyroidism. The TSH was high, but the repeat was normal.
Or it could be an alveolar proteinosis is one of the differentials.
But the severity was milder than the alveolar proteinosis. I mean, of course, you have grades in all the categories. So the CT picture and the grade of the problem, I mean, because the PPHN also resolved, and the baby was clinically stable except.
No, we stay because we have a set of 9 children with alveolar proteinosis, out of which one child with the macrophage dysfunction has undergone bone marrow transplant and is doing well 2 years post transplant. That's my
Excellent.
first child was undergone bone. We have done more than multiple whole lung lavages for these children. And surfactant protein C, we were fooled by one child who came like recurrent respiratory. We thought of everything else. And later on, we sent genetics and turned out to be surfactant protein C dysfunction, who is now on HCQ and doing well. So these kids can present later in childhood as ILD, and they can go past the neonatal period. So I think the children with alveolar proteinosis it's a huge basket, and their phenotypes are very, very variable. And therefore, even a child later on presenting as an ILD could still have alveolar proteinosis, and you have to keep it in mind. We had one with Mars mutation, no, in fact, we had 2 children with Mars mutation. So there are variety of different mutations, and the phenotypes are very variable. But thank you very much for your excellent presentation. I thought we'd like to share what we are doing here in our country.
Amazing. I mean, it's fascinating to know, and also we are proud to know that so much is happening back home as well, though the cost may still be a factor, and the centers like yours might be scattered, maybe 1 per state or less.
We have set it up on a charitable basis because I've got it funded. So we do it at very low costs.
And the organizing team did a great job in bringing both of you, the experts in the field. I mean, Dr.
Thank you.
Thank you, madam, for your comments. Excellent. Your experience in all these cases is really worth sharing, and I think you have done a great job at your center. Thank you very much. Now, once a child with a genetic problem is born, like for example, tracheal stenosis or ILD or PCD, then parents are worried regarding the next issue, like what is going to happen. So we got an expert genetist. So I'll request Inusha madam that if such a child is born, what is the role of genetic counseling? How do you counsel such patient, and how do you go ahead? So please, Inusha madam, please. Inusha madam, are you there?
Yes, I'm
Yeah.
here.
Ji madam.
So 3 cases he presented. One was a tracheal stenosis, and another was a ciliary dyskinesia, and third possibly alveolar proteinosis or surfactant deficiency. Because isolated ILD usually presents late in the adults. And we also, in case of ILD, we also see patients with Niemann-Pick disease, and these Niemann-Pick disease patients also usually present later, not in infancy. What we see usually present later. And regarding the tracheal stenosis, this tracheal stenosis or subglottic stenosis or tracheomalacia, many of these patients will have additional some form of skeletal dysplasia. So additional features should be looked for, like the hand and feet abnormalities or X-ray abnormalities suggestive of skeletal dysplasia, or maybe the child may be having short stature if it is an older child. So these things, if we see, then we can find out that possibly we are dealing with the skeletal dysplasia, and this has also to be managed accordingly. So because many of these patients will have problems in gait and also may have some hip or knee abnormalities. So that has to be taken care of by the orthopedic surgeon. And we have diagnosed patients of subglottic stenosis with Robinow syndrome, and tracheomalacia and tracheal stenosis. They also come. We had also a patient with a laryngeal web, which the child, it was because of Bardet-Biedl syndrome. So different types, we have a tertiary care center, and our genetic clinic is there for neighboring 5 to 6 states. So we get many rare type of cases. And regarding primary ciliary dyskinesia, uh, if a newborn with situs inversus and respiratory distress is there, then you you have a high index of suspicion. You suspect primary ciliary dyskinesia, and you do the testing. And already the diagnosis by use of video microscopy and electron microscopy, that has been discussed. And I will talk regarding the genetic testing, because many of these will be recessive disorders, and severe disorders mostly can be recessive. And in these cases, you have to do, nowadays we have next generation sequencing, and this next generation sequencing can identify up to 70 to 80% cases of these severe recessive disorders. Though we cannot say 100%, because many times we get variants of unknown significance, and when you get variants of unknown significance, you are not sure whether it is actually causing the disease or not. When you have multiple family members affected with the disease, then it becomes relatively easier to diagnose. And one of our SRs was earlier at AIMS, and they had published a series on primary ciliary dyskinesia in 67 patients, and they found variants in DNA, H5 hydin, DNA AF11. So these type genes are there causing primary ciliary dyskinesia, and once the mutations are identified in the background population, it becomes easier to counsel the subsequent families, and we can offer prenatal diagnosis in severe forms of the disease. So if any other questions, I can answer. And regarding the
ILD, madam.
in ILD, as I told, in early onset ILD, there is a more likely possibility of primary alveolar proteinosis or surfactant deficiency. And maybe we don't have some of the other genes, so we cannot diagnose all the patients with neonatal ILD. But in older patients, as I told, Niemann-Pick disease is one of the differentials, and these patients may have foamy cells on the bronchoalveolar lavage, and also they may show cells, these type of cells on a liver biopsy or a bone marrow biopsy. So in the older adult patients or adolescent patients, one can think of primary interstitial lung disease, and in those cases also maybe some genetic mutation can be identified. But we deal mostly with the pediatric patients with severe disorders, and nowadays in most of the severe disorders we are able to detect mutations on a next generation sequencing. But for cystic fibrosis, I would say one should do a CF panel, because sometimes in the NGS testing you may not detect the deletions, duplications associated with the disease. Nowadays, with long read sequencing available, many labs claim that they can give single nucleotide variants and copy number variants both on a next generation sequencing. But it is better to do a targeted panel when we have also deletion duplications as a cause of the disease.
So,
Thank you.
thank you, madam. But actually, the basic question, my question was that if such cases are born in your hospital and the parent ask you that what is the recurrence risk, so how do you go ahead with the counseling? Like they'll ask you that our child had an ILD now and he didn't survive. So how do you counsel them regarding the recurrence risk in future pregnancies?
Yes, if clear-cut diagnosis, clinical diagnosis is available, and lab support is also there. Like you have situs inversus, and you have the ciliary testing. So these type of features are there. You know that it is a confirmed diagnosis, though genetic testing has not been done. Then we usually ask whether they have preserved some sample of the child, or if it is possible to get a sample of the child even if child is not available. Maybe they would have done some test outside 6 months or 1 year back, and we can trace that sample from the lab, and we can do a genetic testing on that sample. The regarding if suppose still we don't get a sample of the child, then we do the counseling that there is a possibility of autosomal recessive disorder, most likely. Depending, actually it will depend on the clinical diagnosis. Sometimes even autosomal dominant disorder can be severe, have a severe phenotype. So in those cases, we would do a carrier testing in both parents, and in most of the cases of autosomal recessive disorders, maybe we'll pick up some of the variants in the parents so that we can explain the phenotype in the child. So we tell that one variant comes from the mother, one variant from the father, and most of these type of disorders are recessive disorders, and if there is a 25% risk of recurrence. So then after the carrier testing is done and we have identified the variant, then we can provide a prenatal diagnosis by doing a CVS or a amniotic fluid testing. So CVS is done around 12 to 14 weeks, and amniotic fluid testing is done around 15 to 20 weeks of gestation, because now we have time till 24 weeks as per the Indian PNDT MTP Act. So we have time till 24 weeks of gestation. And one should remember, while testing for a rare disorder, we should not miss out a commoner disorder like Down syndrome or thalassemia, because if a proper counseling is done, then these tests can be done simultaneously so that we don't miss a commoner disorder.
Thank you, madam. Shilda sir, your both cases, all three cases, they presented very typically. Now, for the benefit of viewers, at what stage you should start suspecting like a child who is presented with respiratory distress or is not responding to your usual treatment? So, at what stage you should start thinking of things like PCDs or ILD? So, for the benefit of viewers, can you give some hint that at this particular stage you should start thinking that is not a usual TTN or not usual aspiration or pneumonia, start thinking of something out of the box. So at what stage you will start thinking of these rare problems?
Thank you. I mean, the airway disorders have usually a complicated diagnostic course, because unless you think about it, you may not pick it up. So stridor may be the presenting feature. In this case, it was a high CO2 in a baby with, or excessive work of breathing, difficulty in feeding. So if you have things which are persisting, especially if there is noisy breathing, get it evaluated as an airway problem. And obviously, slings are more common than the tracheal stenosis and so on. So echocardiography is always essential as skilled echocardiographer, and CT scan may reveal the anatomy, and MR angiography is quite useful as well. So anyway, get a thought process about this if you have concern. So the airway problem is clear because it's not going to be presenting in a typical way. TTN, persisting TTN, usually 5 to 7 days is a window when we start losing patients, and then we start thinking of alternative diagnosis. As far as the interstitial lung disease is concerned, we have the two scenarios. One is where the baby doesn't respond. I mentioned the case where the baby doesn't respond to your initial resuscitation, almost incapable of like acinar dysplasia or severe alveolar capillary or severe congenital alveolar proteinosis, surfactant protein B. So the severe ones will not respond to your initial management. So you may be thinking it's a severe RDS, but despite the maximal support, it behaves almost like a hypoplastic lung or something where you try to oxygenate, but you keep failing. Better to inform the parents early about this so they are not agitated, because these are medico-legal situations as well, where you may be in a well-to-do hospital or a big hospital and the parents are affording, they expect the best of care, but you can't do anything if nature doesn't. So again, the approach to diagnosis, even postmortem MRI or postmortem lung biopsies, may protect you for such cases, because you can be sued for not resuscitating properly in the first place. So this is one group. Then we have the other group which presents like Dr. Indu mentioned about the delayed presentation, and obviously recurrent infections, breathlessness, exercise tolerance may be affected. And if the X-ray has these changes, I mean, the interstitial pattern, coarse crackles on examination is not common in children. So if you have coarse crackles, it would suggest interstitial lung disease. So persisting symptoms, again, few months, recurrent symptoms. It's very common to have viral V's, but don't confuse that with this kind of a wet cough pattern and with coarse crackles and so on. And especially if there is a family history, I mean, we have experts now, better we refer to them for the genetic and further testing. So I hope this answers your question.
Just one comment I'd like to make here. So if I have
Yes,
a full-term baby who has respiratory distress and who doesn't fit into the classical TTN, all right, I'm going to think beyond, because there is no reason like for a full-term baby to have respiratory distress. Like if you ruled out meconium, you ruled out TTN, and or if you have a baby, a newborn baby who has a collapse, right? Who has a collapse. These are kids who have definitely got some kind of mucociliary disorders. So that's the time my antenna would go. And if I have the privilege of them having like a cartogenous, then of course it is like, then it is the diagnosis is staring at you. Even in the if you look at the literature, even if people have cartogenous, the average age for pickup of a child for PCD has been 3.5 years with cartogenous. Without cartogenous, it's between 5 to 6 years. So I feel people should be more alert. And as he rightly said, if anybody has a wet cough, there's no reason for a child to have wet cough. If you have a wet cough, a cough which is persistent and wet, you have to think of mucociliary disorders. Of course, in CF might be on your face because you may have failure to thrive and other symptoms, but PCD is not on your face. So when you have somebody with wet cough, you need to think of PCD. Airway abnormalities are probably more easy to pick up because they're too noisy. I mean, they're so noisy, the parent is noisy, everybody is worried about these kids. So then you will pick them up more easily than not.
more atypical.
ILD is a mixed bag. So right from the newborn period to much later, it is totally a mixed bag. In an older kid, maybe it's easier. Hypoxia, failure to thrive, fine crackles, clubbing, then maybe it's easier to pick up. But in the neonatal period, the differentials are few. Apart from the developmental abnormalities that you see, and you would see surfactant protein dysfunction, these come higher up. The PIG, that is pulmonary interstitial glycogenosis, and the knee high, that is your neuroendocrine hyperplasia of infancy, they come generally little later. Few case reports of PIG presenting in the neonatal period are there, but they manifested because they had associated congenital heart diseases, and they got picked up because of that rather than the PIG causing hypoxia. So in most patients with knee high and PIG, they come with recurrent respiratory crackles, etc. But their outcomes, their prognosis is good in most. Of course, there are a few case reports now talking about knee high not having a good prognosis in a few, but in most it is good. And today a CT scan A simple good CT scan with a good radiologist will pick up a knee high. You don't need to do a biopsy and the Bomi-San staining. So typical involvement of the middle lobes, the lingular and the right middle lobe, classical involvement will pick up a knee high. So I think we need to be more aware. We will be picking these up more often.
Sir, a child with PCD normally is decided it presents with a persistent respiratory distress. Is any other way in which he can present, like for example, a child who doesn't have a certain inversion or dyscardia? Can there be any other way in which he can present it in neonatal period? A child with PCD.
Even this persisting respiratory distress is not a typical common presentation, but if a baby has more than a couple of weeks prolonged picture, about 20% of the cases, such cases may have PCD. And you mentioned dextrocardia. Of course, situs inversus, dextrocardia, or the organ, the polysplenism and so on, organ isomerism. So these should make you think of CD disorders and family history, of course, if you have consanguinity or anyone in the family. But index of suspicion is going to be the mainstay. I mean, unfortunately, persisting symptoms. I mean, Dr. Indu, I mean, in neonatology, even in term babies, we have so many factors which cause respiratory distress. I mean, meconium aspiration, like even amniotic fluid aspiration or congenital pneumonia. So I would say 3 to 5 days for the typical course. But of course, the ones who don't respond well, you have to have a high index from the beginning. So just because it's a term baby doesn't make it more pathology. But obviously, if it doesn't follow the typical course, we have to be more cautious.
So,
Can
do
I
they
answer?
come with persistent pneumonia? Like for example, you are telling to have you seen children with PCD having persistent pneumonia in neonatal period?
I mean, to be honest, I have diagnosed only 2 PCDs in my clinical practice. So that's why we are lucky to have experts who've seen many cases. So it's not a common picture. And of course, collapse in UK, while I was in UK, cystic fibrosis was more common. So we have persistent collapse, you think of cystic fibrosis, and the newborn screening obviously warns you about that. And many of these families have family history as well. So we are already alert to that. But again, in the immediate newborn period, they may not present. I mean, it's usually a little later on. But again, persistent collapse, secretion-related causes, PCD-related causes are important to consider.
We see patients antenatally with CPAM. So we have diagnosed 5 to 6 cases of CPAM on antenatal ultrasound, and also CAOS, that is congenital high airway obstruction. So nowadays, because level 2 ultrasound, 3D and 3D ultrasound is available, so we can diagnose these cases antenatally, and then it becomes easier to do a definitive testing, and then pediatric surgery counseling, and so that way they are better off when the baby is born.
So,
Sir,
thank
can
you
I
very
answer?
much. Yes.
Sir, nowadays, like regarding congenital anomalies in newborn, especially airway anomalies, stridor, the day of the stridor appearance is also matters a lot, sir. Usually, laryngomalacia, they appears after 2 weeks of age. Nowadays, we are seeing a lot of stridor in the first week of life, sir. So whenever there is a stridor within 2 weeks of life, think always beyond the laryngomalacia, like a subglottic stenosis or vocal cord palsies or laryngeal ectasias, like these all kind of all. Because we saw so many, like last 6 months, I'm seeing a lot of stridors within 2 weeks of age, sir. So one child we had a stridor presence in day 2 of life with a hypotonia. Ultimately, because of poor condition, we lost the child by 1.5 months of age, sir. So within 2 weeks of life, or within 1 week of life, if stridor is there, it's a red alarming sign, sir. As madam is saying, it might be associated with skeletal abnormalities or some other abnormalities. So stridor, especially for all neonatals, just stridor within 1 week of life is a red alarming sign. You have to go with other investigations, sir. One thing. Second thing about wet cough, where madam was saying that because I see a lot of bronchiectasis cases, a lot of bronchiectasis cases at the age of 8 years, 9 years, and all. What happening, sir? They are coming with a recurrent respiratory tract infection. People are still treating like an hyperreactive airway diseases, sir. So primary ciliary dyskinesia, as madam, we have so much financial limitations here. So clinically, we are suspecting primary ciliary dyskinesia, but we could not prove it because genetics are little costly, even pheno is also costly. So more of I say that some clinical criteria should come. So like in cystic fibrosis, you will have a malabsorption things. And whereas in primary dyskinesia, usually I do nasal endoscopes also, sir. Usually in primary ciliary dyskinesia, you will have a ear infections, recurrent ear infections. Whereas in cystic fibrosis, you will not be having a recurrent ear infection, sir. And third possibility, we should suspect immunodeficiencies, sir. Immunodeficiencies are in the rise, sir, especially primary immunodeficiencies, sir. So in case of recurrent pneumonias, after the congenital anomalies of the lungs, the second possibilities are PIDs, primary immunodeficiencies. Sir. After that, the ciliary dyskinesia, cystic fibrosis are coming into the role, sir. This is what I observed, sir.
Yeah, Dr.
Okay.
Kasi, I completely agree with you with what you're saying. Immunodeficiency has to be there, but I can, you know what, to suspect a ciliary dyskinesia, we because we have a high index of suspicion, we suspect in many, but still, and we do investigations and all. And if you need help for any patients, they're happy to help you at almost no cost. But the thing is that even if we suspect in many, the number of children whom we finally prove with PCD is not that high. Okay, and most of them are secondary, most of them are still infections, some are immunodeficiencies. Definitely, I would agree with you. And we are definitely picking up a lot more bronchiectasis than before because of the high index of suspicion. But many of these bronchiectasis, I think I've seen an increase in number post-COVID after the lockdown. When the lockdown opened up, the number of infections children got, we have developed a lot of kids with protracted bacterial bronchitis, recurrent PBBs, and then getting into bronchiectasis. Of course, so that is one group which I've definitely seen much more than I've ever seen before. But I feel very simple tests, very simple clinical features will help you diagnose PCD or suspect PCD. So if you have a wet cough which is recurrent, and I've always asked for family history of deafness, like you mentioned otitis media, and if I've seen families where there was a family history of deafness that they became deaf after some time, there is something where my antennas go up that this could probably be a PCD, because the phenotypic variability is huge. In my number of children whom I have PCD, I have very mild PCDs to very severe PCDs. So it is very difficult actually to to sometimes diagnose even with all the investigations possible. But I would leave you with one thought, that if you suspected, please start airway clearance at the earliest. Follow them up. And if after some of them I've seen you do airway clearance, and some of them I really thought were PCD, gave them airway clearance, gave them a little prolonged antibiotic, followed them after 3 months, the child was better, we stopped everything, they're absolutely fine. So it's a mixed bag. So you need to really follow these kids up and really come to a final conclusion. It's not a straight thing. But wet cough is the biggest red herring, that is the symptom that I would be worried about.
Madam, like in all bronchiectasis, every like whatever I saw, madam, upper lobe, right upper lobe with the left lower lobe. So this is a common both in cystic fibrosis as well as primary ciliary dyskinesia, even in immunodeficiency also.
Okay, one more thing I will tell you, if you are seeing lower lobes, even aspirations are much more than we think. We are
Older
thinking
children, madam.
GRD in younger children also, GRDs causing aspirations. We are having children with cow's milk protein allergy. We thought we didn't have them, but now we have children with cow's milk protein allergy who come with irritability, vomiting in the first 6 months of life, and they're vomiting, they're aspirating. I have such children also with bronchiectasis. So you control the cause, and their bronchiectasis at least gets resolved, or at least it gets stopped there, so it does not progress. So it's a mixed bag, and you really need to go deep down into the history, sit with the patient, follow them up, then you will get an answer.
So thank you very much, Dr. Sridhar, for your excellent 3 cases, and they were excellently managed. You have given very good, important, and take-home message regarding a very detailed history, and a very good management can definitely point out towards these rare conditions like trickle stenosis or PCDs or ILD. Thank you very much, Indu madam, for your insight, for your experience, sharing your cases, and I think it was a very excellent experience, and we hope that more and more sessions will take place and we'll hear more from you. I'd like to thank Dr. Inusha madam for the insight regarding genetic management and how to counsel these patients, because these are some very difficult counseling sessions, and definitely you have made things easier. I'd like to thank all the participants who are there online, all the delegates who are there online. Thank you very much, and we again will meet next month, last Wednesday again for a next session on webinar on webinar where we'll have another session. Thank you very much.